Can you continue, Dr. Anya, please?
Yes, yes. So in the left lung, I can see an area of airspace opacity with some green bud nodularity. In the adjacent interstitium with some ground glass changes as well. Um, Rest of
What
the
what's your
bilateral,
differential diagnosis?
um, I won't, okay. Um, Can I see once again, please?
What's your differential diagnosis?
My differential diagnosis is based on any inflammatory changes or infectious changes.
Mm-hmm.
It could be due to any viral or bacterial infection, but it's a small patch, and there's no associated consolidation, no air bronchograms. Um,
So summarized, please.
yeah, summarizing my findings, there is green bud nodularity, which could be due to the endobronchial spread. So I am concerned about infectious changes such as tuberculosis. I like to correlate with the history of the patient in any previous imaging if available and
What
review
will
the
you do
clinical
next?
notes. Next, I will advise the sputum examination and full blood count and follow up.
So
And
you give me two or three differential diagnosis, please, for this case.
okay, next differential could be of it could be due to tuberculosis or it could be due to any fungal infection.
What else?
Um,
What else?
uh,
Okay, no problem.
it's not an area.
No problem.
Okay.
35 years old male patient with hemoptysis.
Okay. So I'm presented with X-ray chest frontal projection of a skeletally mature patient who presented with hemoptysis. The cross abnormality, I can see that there is an homogeneous opacification of the left lower hemithorax. There is loss of silhouette of the left hemidiaphragm, and there is also haziness along the left pericardiac border. Um, I can, if I trace the border of the left bronchus, I cannot see the left pulmonary artery, lower left pulmonary artery, and there is a triangular opacity in the left retrocardiac region, and
What's
there
your
are signs.
differential diagnosis?
So my diagnosis is the left lower lobe collapse with
Yes.
bronchus cutoff sign. So
What will you do next?
I will alert the clinical physician of the possibility of any underlying mass lesion, and it needs to have an urgent CT scan to rule out any underlying
This
mass
is a
lesion.
CT scan of the patient, 35 years old.
All right. So I can see that there is um, cavitating lesion seen in the left lower lobe with some bronchograms in the collapsed lung as in the collapsed segment as well. Can you just scroll once again? I want to see the bronchus.
Please, Doctora, oh, yeah, there are some holding candidate. Can you add them, please?
Yeah, just a second. I'm not able to, like, I think I have made you the host. I'm not able to see the signal now.
Okay, okay.
I'm not getting that admitting thing.
And there is a collection formation maybe in the lungs.
Mm-hmm.
So I'm concerned about the necrotizing pneumonia as well on the background of uh, lung changes.
So, what's your differential?
Can you
What's
please
your
on the
differential diagnosis?
corner section as well?
What's your differential here?
I just want to see that it's along the chest wall. Uh, yeah,
Not just
it's
well
along the
invasion. Not just well invasion.
no chest wall invasion. Yes.
Mm.
So it's like a lung abscess formation,
Yes.
or yes,
What
with
else?
multiple lung tools, or it
Okay.
could be empyema formation.
Okay.
Um,
Excellent.
but I do not see any. Yeah, I'll see any split through a sign.
Okay.
Yes, I think. Yeah. And I'll see it's that there may be visualization with the bronchus and the pleural space, which is causing this problem.
Okay. What else? Do you think to do you want to see something
But
else?
yes, I want to see the contralateral lung and if there are any associated lymph nodes in the mediastinum.
Okay. To which MDT would you refer this patient?
I will refer this patient to the mm lung MDT and will require further advised bronchoscopy and
Okay.
biopsy and the will yeah. And
40 years
drainage of
old.
this.
40 years old the patient with dyspnea.
All right. So I'm presented with scanogram um, of a patient who presented with dyspnea, 40 years old. I can see that there is lobulated mass lesion seen in the mediastinum. It has lobulated margins laterally and which are sharp and well defined with the lung. Um, there is loss of the right cardiac border, signifies the mass is in the interior mediastinum. However, there is no mass effect on the trachea. Trachea is central in position.
What's your differential
Um,
diagnosis?
my differential diagnosis would be of lymphoma or
What else?
less. Yes, next would be of thymoma
Yes.
or any thymic lesion, or down the list teratoma, and then goiter will not be in this list.
What will you do next?
Next I will advise cross-sectional imaging for further characterization and to see the adjacent invasion and the mass effect on the adjacent mediastinal vessel. Okay, so I'm presented with CT scan axial sections in the mediastinal window of CT thorax. There is myeloid pleural effusion. Um, I can see some fat density in this. However, in my routine practice, I will take the Hausenfeld units. Um, there is also differential densities, some hyperdensity in it as well. So it is also interior in the location and is closely adherent to the
What's your
pericardium.
differential here? What's your
Yes, my
differential?
differential here, yeah, top differential here would be of teratoma. I will like
What
to
else?
compare with the previous.
What else?
Uh, it could be thymolipoma, or
Excellent.
it could be less likely lipoma because it has differential densities and soft tissue density in it as well. I will want to have a post contrast examination if available to see if there is its relation with the vessels, any mass effect or mm,
More than
the
excellent,
scheme.
Doctora. More than excellent. I will wrap up rapidly. Did we finish the 15 minute or no? No, any timing.
Yes,
Anyway,
yes,
yeah,
yes, we
yeah.
are.
See also my colleagues, this is another example of another example of candidate who start very well and they get 7.5 at least in the first case, and then get confused, stressed, and I'm
Mm-hmm.
trying to help, struggling, and then finally she can stand up again and get a better mark. This is a scout film. You didn't tell me this point. This point. This is very important to the examiner that you know this is scout. This is not an X-ray. Second point, you tell this is
Yeah, I
anterior
think
mediastinal.
scanogram.
Hmm?
Yeah. I think I used the word scanogram.
Yeah. Sorry. Then you tell very well this is lobulated mediastinal obscuring the heart. I can see there are. Did you mention there are hilar over lysine or not?
No, hello, Alexa, fine. I didn't
Yeah,
mention that.
yeah. See, this is very important. My colleagues, the examiner want to hear from you, listen from you some buzzword. And really, he did like I do. He interrupt you. What's your differential? What you or manage like this? So try to precede him with one step. Try don't narrow it too much. Try to, no, he
Okay.
didn't, he's not his matter to tell what physician in the give him a good diagnosis, differential diagnosis and management. And then he don't care finally if you transfer to cardiothoracic or to pulmonology. Okay, it is very important, but concentrate on the essential critical point. You did very well, but I think also you didn't mention there are hyperdensity at least here.
Yes,
And
I thought,
then
yeah,
Mm. And then
yeah.
you did very well. This is a mask containing hypodense content, most likely fat and calcification. It is
Mm.
most likely,
Teratoma.
most likely teratoma.
Mm.
However,
Teratoma.
if you wanted to get 8 by 8, tell him. However, I couldn't detect any pleural metastasis, precardial metastasis. So it is mostly mature teratoma. My differential diagnosis would include simulipoma. uh, lymphoma is not a possibility. Like this, you close the cases 2, 3 minutes maximum. The examiner will be happy. Okay. Here, here you struggle,
Yeah.
and you forget one life saving one. And I many times I do like this. Go
Aneurysm.
and come aneurysm.
Yeah,
Aneurysm.
aneurysm.
This is very important. Okay, no problem. This is acceptable before the examination, and this is the target of our session here to pick up the weak point. Okay, this is consolidation at least with in between inside air lucency. Okay, in the left lower
Mm.
lobe surrounded by consolidation. So my differential
Mm.
diagnosis, first abscess, empyema, whatever, but this is most likely abscess because see this is يعني not fluid,
Yes.
because if this fluid we should
Exactly
see
right.
some air fluid level. So it is abscess
Yeah.
complicated with left lower pulmonary artery aneurysm. This is an emergency. First, I should immediately pick up the phone and telling the referring clinician, and I will refer to either interventional pulmonologist, radiology, to what? To put
For
first
hemolysis.
stent, no,
Mm.
okay, but under high coverage of antibiotic. What type of this aneurysm? This is a mycotic aneurysm. This
Mm.
is a mycotic aneurysm. First, the
Yeah.
patient should be covered by a high umbrella of antibiotic. This is very important. Then I think the intervention is not يعني not a need in the first few days because the tissues is very friable. I'm not expert in the intervention, but you mentioned this is need first
Mm.
high coverage antibiotic, and I'm so worried about this aneurysm. I should tell his referring doctor, okay,
Mm.
to discuss the matter with the intervention. You are here in the fair borderline situation. You didn't tell
Yeah.
to be operated for intervention, and you didn't neglect. Like
Yes.
this, I will give you, any examiner will give you a phone. Okay. Second case, you delayed and confused. First, you start very well. This is an X-ray of the patient who has a persistent for 1 month complaint. You did very well when you told me, oh, this is persistent chronic, you should do CT. Very good. We came here, we came here, you pick up some opacity. Okay, this is ground glass opacity, not opacity. The difference between ground glass and consolidation is you can see the vasculature of the lung through the ground glass because this is a partial opacity, not a complete. The alveoli is not completely filled. Okay. The consolidation completely obscuring the vasculature. This is a very important point. Second, give me a good, reasonable differential diagnosis. You told TB, okay. And what else? Fungal, okay. And I ask you, what else? What else? Many types. Carcinoma. One of the most important presentation of the lung cancer is ground glass. And then tell me I will transfer, I will do, okay, no problem. But try to mention as possible as related differential diagnosis. Okay.
Okay.
And by the way, this case finally was diagnosed as bronchogenic carcinoma.
Bronchoalveolar. Yeah.
Mhm. This case delayed diaphragmatic rupture. First X-ray is nearly normal. This is a positional, just
Right.
shifting to the, it's a positional. Then
Hmm.
this patient is a polytrauma. My colleague took a home advice today in polytrauma patient. Try to tell the examiner, I will examine the patient again to rule out delayed diaphragmatic rupture. And then you mention everything. There are elevated copula, there are bowel containing gas in the right hemidiaphragm and opacity. I ask you last question to give you the highest mark. How could you be sure this is a diaphragmatic hernia by X-ray? I'm waiting from you to tell me, oh, I can introduce one nasogastric tube and already this is the nasogastric tube here. The nasogastric
Right.
tube, this one. See, this is a very sure sign of a diaphragmatic hernia. Okay,
Yeah.
I forget to tell you something. Could you remember?
Yes.
This case has a large lower lobe consolidation. Mostly, this is collapse. Okay. And because the patient is still young, see, female patient 35. So, first differential diagnosis is carcinoid. This one. I think I mentioned there are something obstructing here. So, I think
Yeah.
so this is a carcinoid with collapsed lower lobe. What is the
Okay.
next? The next step is dotatate
Donut.
scan.
Yes.
Do this is dotatate. See, I think this is the mass that I pointed during the exam. There are obstructing mass, and the rest is a collapsed loop. See this. Do you remember I told there are some obstruction here,
Yeah.
and this is collapse. Finally, I want to tell you, all of you are really, really impressing. You have a very good knowledge, and all the mistakes of today is very expected. All of us, all people who passed FRCR did a lot of mistake, which were more than this. Really, I'm not joking. So what should you do? Practice, practice, practice. Practice with yourself or with your friends as much. Whatever you see suitable for you, practice. This is a case. You wanted to see this case, Dr. Anya?
Yeah, the pulmonary artery aneurysm. Yes, this one. I just want to see the side aneurysm.
The aneurysm on the left side, the aneurysm affecting the left lower pulmonary artery. See? Try to make some notes. If I am in case of infection or severe infection in the lung, I should exclude pulmonary embolism, pulmonary
Oh,
aneurysm. What do you detect?
yeah, now, yes, now I can see. Yes, it is inside the lesion. Yes.
Yeah.
Okay, what type? This is a mycotic aneurysm. Okay.
Yes, yes.
Okay, my colleagues, I was very happy today. Let's يعني complete our sessions next Thursday, inshallah. Study well, stay motivated, you can do it. Okay.
Thank you, Dr.
Okay,
Rami.
thank you
Thank you
so
so
much.
much for
Well,
the wonderful
well,
session.
welcome,
Thank you so
welcome,
much.
Thank you, doctor.
welcome anytime, welcome.